We're so glad that you're here today for our ICU DDR webinar presentation, and we're really fortunate to have Beatrice here with us today. And if you don't know, I'm Carrie Hopkins-Iles, and I'm the Deputy Director for ICU DDR. And we're going to be providing multiple webinars in the next few months, especially with the current pandemic. We want to be able to provide free education where not everyone can travel and we can't travel, so we want to be able to provide different topics for you. Throughout the presentation, please feel free to type questions into the chat function, and at the end I will be asking Dr. Kathungu to answer those questions and indicating who has presented the questions. So with that said, we're going to hear from Beatrice, our lecturer in the Department of Psychology, Kenyatta University, Nairobi, Kenya. She received her PhD in counseling psychology from the same university with a specialization in the area of rehabilitation of children in the juvenile justice system. She's served as a full-time faculty member at the Department of Psychology at Kenyatta University for 16 years. And she has steered the adaptation of the Universal Treatment Curriculum, the UTC, which many of you are familiar with, and we work closely with at ICU DDR. And she's done that for 16 years. And into the first specialized postgraduate program in addiction treatment science in the region at Kenyatta. And she's providing leadership and mentorship to other universities in the region, which we're grateful, very incredibly grateful for. She works closely with the Kenya government through the agency, the National Authority Campaigning Against Drug Abuse, as a researcher, consultant, and clinical supervisor for counselors in the National Drug Helpline. She's also a founding member of ISIP Kenya chapter, where she serves as the chair of the Research and Dissemination Subcommittee. And she is a global master trainer for the UTC Basic and Advanced, as well as the child curriculum, and she's conducted numerous trainings on the same in Asia, Africa, South America, and Europe. And I am so glad to have her today for developing university-based DDR academic programs. So with that, I will hand it over. Thank you.
Thank you, Carrie. I'm very pleased indeed to get an opportunity to be here. It's an interesting experience, different from a face-to-face seminar, which I'm more familiar and used to, but I'm trying to get used to this, particularly in these tough times of COVID-19. So I'm glad to be here, and I'm glad to have the participants and share my experiences with them. I wish to acknowledge the opportunity given and thank each one of you for finding time to be able to be part of this webinar. As Carrie has said, I am actually sharing my experiences and our experiences from my university, where I was head of department during the time that we developed this program. And I have been feeling that it's an important milestone that I need not keep to ourselves, but share with fellow members of ICU DDR and stakeholders that would be interested in getting to experience and to know what it has been like as we walked this journey. And therefore, I'm going to be sharing our experiences. I'm going to be sharing our challenges. And I'm also going to be reflecting on the opportunities that are available, particularly for countries that may be resource constrained, such as Kenya and other countries in the developing world. Probably I'll begin my presentation by asking myself an interesting question. Why do we need DDR or drug demand reduction academic programs in the first place? And I'm just reflecting on what many of us are familiar with, the global problem of drug abuse. We have familiar with the UNODC report on drugs in 2014, and the statistics are very glaring about the kind of problem we have globally in terms of drug abuse, the number of people in the ages of 15 to 64 that use substances, and even the numbers of people that have drug use disorders, and the numbers of people that are at risk of developing HIV/AIDS and hepatitis C because of using injectable drugs. And that really means that we need to address this problem by treating these persons. All these problems of drug abuse have a significant impact, as we are aware, on different spheres of life, on health, social, psychological, and even economic. And therefore, we cannot sit back and watch. We need to think about what we can do. The other reality that we have globally is that we have limited capacity in terms of evidence-based prevention and treatment. And therefore, we do have a need to have what is called, or what I'm calling, sustained capacity building, so that we ensure that we are promoting evidence-based practice as a way of enhancing our client outcomes. And therefore, I reflect on what we can do as universities. And I ask myself, why do we think that as universities we should be even thinking about offering drug demand reduction programs? And I reflect by saying that one of the basics that we enjoy as universities is that our core mandate is actually education and training. It's also research and generation of knowledge, and it's also dissemination of that knowledge. And that then means that if we were to offer drug demand reduction education and capacity building through universities, then it's actually going to be a sustainable approach, as opposed to the many other approaches that are happening globally. Because by using universities, we can take advantage of an infrastructure that's already in place for training and education. Now, what does it take to develop an academic program? It does take resources. These resources could be financial, they could be material, including teaching and learning resources, they could be human capacity, they could even be technological resources. And we have to think about this every time we think about developing academic programs. And that brings me then to the whole question of resource-constrained countries, like my country and probably some of our countries. And I was reflecting on what it means to be resource-constrained, and I was actually thinking about the definition. It just refers to the situation where we have limitations of inputs that are available to complete a particular job, whether it's people, time, equipment, and supplies. And then that means that for development of academic programs, which we have said requires resources, and we are talking about limitations in these inputs, then we have to think about that as countries coming from these kind of backgrounds. The resources may actually be available, but the demands are many and competing. For example, if you think about your countries and I think about my country, we can think about some of the competing interests to education. We have got health. I mean, in times of COVID-19, I think it's going to be even more challenging now as resources are diverted from other areas towards this health concern. There are issues of housing, there are issues of basic education, fighting and eradicating poverty. And because of these challenges then, it means that each time we think about developing programs, academic programs, which require resources, we have to always remember we're in a framework of competition with other equally important needs. Now, what are the key considerations when we think about developing drug demand reduction programs? We have to think about effectiveness. We have to think about efficiency. How well are you using the resources that we are saying are limited to achieve the maximum that we can? And of course, and most important, we have to think of sustainability. How long term can what we are trying to put in place be? That's an important thing. The other important thing we have to keep in mind is our goal. What do we want to do as universities? We want to develop drug demand reduction programs, but we also want to make sure that these programs are evidence-based. I know it's possible to develop lots of academic programs, but the question is, are they based on evidence? Are they based on output that has been, supported by data? So that's important for us to keep in mind. And of course, finally, we need to keep in mind our commitment to quality, because at the end of the day, the effectiveness and efficiency and sustainability of the programs we develop will really highly depend on the quality we put in. And therefore, I think as universities, we have a big responsibility. And what is this responsibility? First and foremost, we are going to be responsible for making the knowledge and evidence that's available accessible to people. When I think about people, I'm thinking about practitioners in the field of SUD treatment and prevention. I'm thinking about potential practitioners who have not gotten into the field as yet, but who will probably be getting into the field in the future. And I'm thinking that what we can do is engage in capacity building so that we ensure that this evidence-based knowledge can actually reach these practitioners and they can translate it into action and hence enhance the outcomes of the clients. That's where we come in as universities. We have a strategic advantage. Remember our core mandate that I said, it's education and training. In most countries, and I believe your countries as well, universities are considered the apex of education. They are the apex of quality. So the world, even right now, is looking up to universities to give answers to problems of COVID-19. So we enjoy that advantage that society looks up to us as the apex of education. We are likely to be trusted more than other providers of education and training if we as universities offer these programs. Secondly, we have a commitment to quality as universities. I do know that virtually all universities have got quality assurance mechanisms that are geared towards ensuring a level of quality in all the programs they offer. So that's inherent in our institutions. I have already emphasized that we enjoy a level of trust by our communities and societies. And of course, finally, I do think many of us have investment by governments, particularly those of us who are in state-run universities enjoy some level of investment by government. And therefore, all those are advantages that we can think about. But at the same time, we also have challenges. And part of these challenges includes the following. We have shrinking funding to lots of universities as the global economy faces various challenges. And I can almost begin to think that as we think about the long-term impact of Corona, this is going to be a reality we have to contend with, that funding to universities is going to shrink as competition for resources to fund health and bring back the economy become a reality. We also have competing interest in terms of other programs. In my university, there is the whole question of we want to offer medicine, we want to offer engineering, we want to offer all these other courses that are going to be competing with our drug demand reduction curriculum. The other important challenge is the changing target market needs. As the market needs change, again, we have to ask about the relevance of what we are proposing as a drug demand reduction program. Other challenges include debates that are in many universities about, do we go art, do we go sciences? I know that in some countries, you find people feeling that the way to go is sciences. You have had all this emphasis on STEM subjects. And I know every time we think about mounting a program, then there's the question of, is it friendly to what the debate is at the current time in our institutions and in our countries? The other important challenge we have to think about is how do we make our institutions commit their internal resources to support our programs? How do we convince management to own the program and to give us some level of goodwill? How do we supplement the limited internal resources? And is it possible for us to consider mobilizing external resources through partnerships and linkages? And these are all ideas and challenges that we must reflect about. We also must think about challenges like reaching the target population. Who are they? Where are they? What do they want? How do we ensure that we are maintaining their interest and their goodwill? And all this is important for us to reflect on as we think about academic programs. But despite those challenges, we have lots of opportunities, like we have said. And what we need to do is we need to innovate approaches that can create a niche for our drug demand reduction programs in our institutions. Secondly, we need to convince our institutions and critical stakeholders to invest in our DDR programs. What that means is that we require to do a lot of advocacy as stakeholders in this field. We also must identify who is it that can be our partners and map them out. We also need to think about what are the opportunities we have both at the local level as well as the international level. And of course, and very important, and I think that's part of what we are doing right now, we have to build synergy across universities, across organizations, across countries and regions, and even continents. Next, I want to share my reflections on our Kenyan experience. What is it that we did? Now, one of the things that I want to share is that as a country, we had a big drug problem. The National Authority for the Campaign Against Drug Abuse, which is the government agency that leads the campaign against drugs and illicit substances in Kenya, called NACADA, has constantly done research to try and give us an idea of what the national problem is. And some of these statistics you see came from NACADA in 2017, that 18% of people had used at least a drug or another, and some of the key drugs were alcohol, tobacco, cat, and cannabis, among others. But in addition, there were also several people with substance use disorders, and the leading was alcohol use disorders. Alcohol use disorders is a big problem in our country. Of course, we had those who had tobacco and the other drug use disorders. And what that means is that beyond prevention campaigns, we also have to think about treatment. We observed that there were several treatment centers in Kenya. Unfortunately, many of these were actually run by persons in recovery. These people had limited training and limited capacity to offer evidence-based treatment. And there was generally a shortage of the professionals, and there was also limited availability of training that was focusing specifically on substance use treatment and prevention, because many of the practitioners who are working in this field had some background in related disciplines like psychology and counseling and psychiatry and medicine, but little, concentration in terms of specialization on treatment for substance use disorders. And therefore, there was a need to develop programs that could actually target expanding treatment capacity and that were evidence-based. And therefore, we identified the problem and there was a need. So how did we address this need then as Kenyatta University? First is that we identified our anchor point. We needed to think about where to anchor this problem. So we looked at our university philosophy, our university vision and mission. And we noticed that the philosophy of our university talks about sensitivity and responsiveness to societal needs. We also noticed that in the vision and mission of our university, there was teaching, there was learning, there was research, there was quality education, there was community service. And that therefore means that we had a place at which we could anchor our program. And therefore, we anchored our drug demand education program on the philosophy and mission of the university. Specifically, we saw that there was a need, and we thought that our university could actually respond in line with its philosophy to that need. And we thought that then we could use our university to translate the SUD treatment evidence into practice as a way of enhancing the treatment outcomes and therefore reducing the significant impact of drug abuse in the country. The second thing we did was to examine our strategic advantage as a university. We noticed that our university is the second largest public university in Kenya. We also noticed that it has recognition both in Eastern Africa and the larger Africa. We also observed that it had a network of campuses that was spread across the country, which means that if we wanted to reach practitioners across the country, then our university had that network. We also noticed that it had diverse student cultures, and it had also diverse faculties, both in areas of arts, sciences, and technology. It also already had approval to offer diverse programs, from certificates all the way to postgraduate programs. It also had approvals to offer diverse modes of study, whether face-to-face, whether digital and virtual learning, whether part-time or regular. All this was within the structure of the university. The university also had a very well-established departments and schools or faculties, and that means that it was easy to anchor the program in any one of these departments. There was a diverse and vibrant faculty. There were reasonable resources which were being used to offer other courses, whether it was ICT infrastructure, library, and e-resources. There were also very clear policies on curriculum development, approval, and quality control, which then means that it was easy to tap into this. And of course, there were also clear policies and structures on partnerships and collaborations. And in fact, at that point in time, partnerships and collaborations were being encouraged by the university management. Now, having looked at those strategic advantages, then we defined our goal. And our goal was to translate evidence into an academic program. And there was the question of where do we find this evidence? How do we access it? How do we disseminate it? Is it already packaged or do we have to package it? And I emphasize that we recognize that we do not need to reinvent the wheel. The Colombo Plan with support from INL has spent a lot of resource and time and effort to develop a universal treatment curriculum. And therefore, there was no need to start developing curriculum if already one that was evidence-based was existing. And therefore, we wanted to tap into that. Fourthly, we identified our target population. We thought about who are the relevant stakeholders in the field of substance use treatment. We considered those already working in the field, And we also thought about those aspiring to work in the field in future. That means they have not necessarily joined the field, but they could be joining the university or already in the university with other degrees, but hoping to work in the field of SUD. So we needed to determine what they need, and therefore we carried out a needs assessment. Now, as you think about the needs assessment and as we think about the target population, we learned several things, that it's important to recognize that the field of substance use treatment is diverse and complex. Diverse in which ways? First, many people work there from diverse disciplines. We have physicians, we have psychiatrists, we have nurses, psychologists, counselors, social workers, among others. At the same time, the treatment settings are complex and diverse. For example, you have inpatient, you have outpatient, you have hospital settings, you have workplace settings, educational settings. And thirdly, you must also recognize that we have diversity in cultures. And these are things to keep in mind. And therefore, when you're thinking about what you need, we realized that we needed to find out, with all this diversity, what knowledge, skills, attitudes, and competencies would be required if people are to work effectively in these settings from an evidence-based perspective. We had to find out what are the current gaps and challenges. And this was important because we needed to ensure that we captured and addressed them in our curriculum as a way of ensuring that our curriculum was going to remain relevant and market-driven. The other important lesson we learned is that you need to consider several things. You need to think about how to make your curriculum available. You need to think about how to make it relevant, suitable, acceptable, particularly because of culture, how to make it feasible or practical, how to make it adaptable or flexible, how to make it accessible, and so on and so forth. So these were factors that we had to keep in mind and that one needs to keep in mind. Now, at the fifth step, we needed to concretize our goal. Now, for us, our goal became, we needed to design a university program that addresses the needs of practitioners in the field, both those already in the field, what we would call some sort of in-service training, but also those aspiring to join the field in some form of pre-service training. The other important thing we had to think about is that we wanted to ensure that our curriculum was anchored on evidence-based knowledge. Now, at number 6, we had to think about how to look inward. Now, for us, looking inward is asking ourselves, what is already in place in the university? What is it that we can tap into? So when we looked inward, we discovered several strengths that we could, and opportunities we could exploit. First, we looked at the Department of Psychology. We realized that the Department of Psychology was vibrant, with young faculty that were enthusiastic, and a head of department that was passionate about the drug demand reduction agenda. And we realized that we could tap into that and the goodwill of the management. There was already available expertise that could help in developing program content and the delivery methods. There was already some human resource capacity in related fields of psychology and counseling that could actually be used as a resource that was already existing inward. Now, there was also some basic infrastructure in the university that is used for other courses. We had lecture halls, human resource, library resources. We also already had policies that support partnerships and collaborations. And we also had very well laid out curriculum development and approval policies and processes and systems. So this was already an asset that is in many of universities and that was in our university and that we can tap into. Now, we also needed to look outward because we were not self-sufficient. So in looking outward, and particularly in the spirit of our university encouraging collaborations and partnerships, we looked outward. We looked at the missions of different organizations. We looked at their visions and we actually found relevance and commonality. And this is important because at the end of the day, I say we are many organizations who share missions and visions, just that we have different routes, but the destination very often is the same. And therefore, we need to find the point of connection at which we can actually partner and exploit each other's resources. And so for us, some of the partners we looked at was NACADA, which is the National Authority for Campaign Against Drug Abuse, the government agency in Kenya. We looked at Colombo Plan, which became a partner through the DAP program. We looked at the treatment centers in our country, private and public, that were critical stakeholders. And this became critical because when we reach the point of wanting our students to get attachment for practicum, we would need them to work in these treatment centers. So all these were important, partners that we looked out and we formalized partnerships with them through memorandum of understanding and memoranda of agreement. And this is important. And so really what we are saying in the next step is that we establish the partnerships. And at this point, I just want to emphasize that one of the lessons we learned was the value of ensuring that we sign these agreements so that we do not get into bottlenecks along the way when we have started the journey of partnership. So that really is important. The other important step we did was to determine the level of program that we want to offer. This was actually guided by our needs assessment. It was guided by our considerations of accessibility and feasibility and whom it is that we were targeting. And remember, for us, we were targeting those who already were in the field, but also potential. And so for us to be able to accommodate all those people, we needed to have a program that was going to accommodate people with already a degree and working in the field. And that's why we opted for a postgraduate diploma. Now, a postgraduate diploma in my country is offered to people who have a first degree in whatever other field. And so for us then, it meant that the people working already in treatment centers as psychiatrists, as nurses, as social workers, as counselors, could then join our program for further capacity building. And that then meant we would be able to reach our target population. Now, the other important thing is we determined the nature of the program. Do we want a standalone or do you want an integrated program? All this really does depend on the specific university resources and circumstances. If developing a standalone program is impossible, it is possible to integrate certain elements of a curriculum into existing courses. But for us, we decided on a standalone program, looking at our circumstances. And so we adapted the UTC, which is by Colombo Plan DAP with funding from INL, and we enhanced it with our own university local context and material that's relevant to our local needs. And then we were able to align it to our program learning outcomes, which we had obtained from our needs assessment and assessment of the competencies that we wanted to build. Now, we then determined the program structure, which is very important, including the duration of the program. Remember, we are talking about, for us, people who already have a first degree. So we needed to ensure that the course length isn't too long as to put them off. And therefore, we designed a one-year course, which is basically 3 semesters, 2 semesters of coursework, and a 3rd semester of practicum and a mini research project, which is trying to put in place an evidence-based practice and assess its efficacy. We then engaged the curriculum approval mechanisms. I believe in every university, we have got internal mechanisms and we also have external mechanisms. For my university, we have different levels all the way from the department to the school and to the university senate, which is the highest authority. And once that is approved, then the curriculum is taken to the external regulatory body for approval, and that we were able to do. Now, the next thing was to enhance the staff capacity. Remember, we did say we had some level of capacity of staff that were teaching related courses or had some experience in some of this material. But we wanted to ensure they're well grounded and they also understood the spirit of this program, that it was, a program designed to emphasize the need to put evidence into practice. It was experiential. It was a hands-on course. And so we conducted a university-based walkthrough in partnership with Colombo Plan DAP and funding support from INL, and we really acknowledge this support and were able to do a walkthrough for about 21 of our staff. Now, where are we right now? We have successfully launched the program. Actually, the first class was in May 2019. The Postgraduate Diploma in Addiction Treatment Science is the name of the program. It has a strong emphasis on science, a strong emphasis on practicum. Now, the first class is currently undertaking practicum. We hope that they're going to complete and graduate with or without Corona in December 2020, hopefully, if all goes well. So that is where we are. Now, where do we want to go? We want to expand access. We are hoping to launch different modes of delivery for this program, including face-to-face, including part-time classes, including possibly virtual and open learning. And I think there is no better time to think about than now. We also plan to think about higher level programs such as a master's degree and possibly a PhD in future. And we also want to consider developing a prevention-based program now that this is a treatment-based program. Important lessons, really just in summary, is that universities are valuable as centers for expansion of evidence-based practice, particularly for sustainability. Secondly, that is important in buying in the university management for purposes of goodwill and ownership if we want to succeed in mounting programs in universities. And thirdly, nothing can beat the power of partnerships and collaborations. And I'm extremely glad that ICU DDR is actually part of the journey of bringing us together for partnership. As a parting shot, I wish to acknowledge the following people that have made our dream a reality. I want to acknowledge Colombo Plan DAP. I want to acknowledge INL for the funding support. I want to acknowledge Nakada Kenya. And of course, I want to acknowledge ICU DDR because they're giving us a wonderful opportunity for partnership to build capacity for greater achievements, not just for us as a university, as a country, or as a continent, but basically the big world. Thank you very much. And now I welcome comments and feedback and questions. Thank you, Carrie.
Thank you so much. That was excellent. So we have a question. I'm terrible with pronunciation. So Adrie is the first name, Adrie. How was the initial assessment conducted to identify the gaps and challenges?
Okay, thank you very much. So Adrie, thank you for that question. So part of curriculum development in my country requires that you do stakeholder engagement. So part of the stakeholders we engaged was actually the NACADA. We also engaged treatment providers, particularly those from treatment centers. We also engaged some of our alumni students that have graduated and gone into practice in our treatment centers. So those are some of the people that we engaged, and we did a survey basically and got feedback from them. So that's how we did the assessment. Thank you.
And then Clara asks, do the learners receive the international accreditation as there is a partnership with DAP and Colombo Plan?
Thank you. I don't know if it's Clara or Claire. Thank you for that question. We do hope that once they graduate with our postgraduate diploma, then the next thing is to enroll them for the ICAP examination so that they can then get the accreditation. So we hope they will have dual certificates, the Kenyatta University certificate and the ICAP certification. Thank you.
That may have already answered this next question, but what is the nature of the written exams? Is it the ICAP?
Now for the written exams in my university, we basically have a variety of them. We have got continuous assessment tests. We have got final examinations. We have got projects. We have got practicum assessments. We have got project supervision, all these consolidated comprehensive methods of assessment for the university examinations. But for the ICAP exam, it's the external exam, which basically from my experience is multiple choice based examination. I'm not sure if I answered the question as was asked, but that's my input.
Okay. We're getting some nice comments. Thank you. Very good introduction to the activities of ICU DDR. I hope to gain from some of these educative programs. Well done. Thank you for the presentation. Does the curriculum cater for adolescents and adults?
Now, the curriculum caters for treatment in general, in terms of content, in terms of who can join the program to be trained. It is anybody that has a first degree in a related field, and the related fields are social sciences and health sciences. That's what we have picked. So in terms of catering for adolescents and adults, in terms of the curriculum content, yes, it does, because it's a content that's for treating everyone. So yes, it does.
Many comments about what an excellent job you did. Did you have Did you have to adapt the UTC program in any way?
Yes, thank you for that question. We had to adapt the UTC curriculum. We actually adapted in several ways. First of all, we took in the basic UTC, but we also took in some advanced courses which were not in the basic because we realized they are critical. We also took in some courses from the recovery coach, the community-based support systems, courses, because we knew in our culture, a lot of treatment is community-based. So we added much more than the basic UTC. But at the same time, we also had to adapt the content. Sometimes the content was not sufficient to take, the entire period of a semester. Remember, university is semester-based. So we had actually to build some of this content so that it could be, well-grounded. The other thing we had to do was to add some of the content that is expected by our university of a university program. For example, we had to put in a research-based, a course. We also had to put in practicum and develop a practicum course for it. We also had to develop a mini project course to go with this program. So all these are parts of adaptation. In some areas, we adapted content. In some areas, we adapted methodology, and we enriched the curriculum so that it would meet the needs of our country and the needs of our markets as a country. Thank you.
Okay, what types of research projects are students required to do?
Now, our research projects are actually, we call them mini research projects. And why we call them mini research projects is because of the time duration of this course. So we want them to do a project that will last about a semester. A semester is about 3 to 4 months. And therefore, we are careful about the weight of how much they choose to do. Secondly, we want to promote evidence-based practice. And therefore, even the project they do, we want them to actually think about, in a little way, within the practicum site they are working, can they work with the center to implement a small, evidence-based activity and assess its impact? And we support them as faculty to look at that, so that we want the students to begin to learn how to apply research methods, and we want them to learn how to apply evidence, and we want them to learn how to monitor the evidence that they are applying and how to evaluate it. So that it's a very interesting kind of project. It diverts a little from the typical research project that we are familiar with in universities. And it's actually a sort of a hybrid between practice and project. And because it's the first time that we are doing it, we're going to be reviewing it, and I'll probably be making some presentations and sharing our experiences, particularly of the practicum and the project, as we have seen them through this program. Thank you.
How hard did you find it to adapt the content to fit into a university course or calendar?
Actually, it was not very easy, because a university calendar has a specific number of credit hours in terms of time frames, in terms of contact hours. And so some of the courses had very heavy material. Some of the UTC courses had very light material. And so we had to ensure that we made them fit into what is a curriculum acceptable to a university, even for purposes of approval by the various organs of the university. But the beauty is that we had our faculty that were very determined and dedicated. And therefore, we sat long hours and we did several retreats, I remember, to work on that curriculum and put in our expertise and put in our experiences with having placed students in internship in those treatment centers and the feedback we had received from the stakeholders. So it was not easy, but it's doable. Great. With commitment.
What criteria do you give for centers where the students do their practicum? Do you allow both government and private treatment centers?
Thank you for that question. That's an important question indeed. And for us, the criteria number one is that the center must be approved by the national authority that approves treatment centers. That is actually NACADA. That's why NACADA is a critical stakeholder for us, because then they give us a list of the treatment centers they have accredited, and they accredit after they have ensured that those centers have some basic minimum. And so those are the centers that we send our students to. They can be private and they can be public, but they must have been accredited by the accrediting authority. Thank you.
And for the practicum as well, how long do the students do the practicum and how is it evaluated?
So the practicum is a 3-month period, but it has got a certain number of contact hours. So we have broken it down. It's actually very detailed. It has got the client contact hours, it has assessment hours, it has got group work hours, it has individual work hours, case management hours, supervision hours. So there are lots of different elements that make up the practicum, because we realized that it wasn't enough to just tell students, go out for 3 months and come back. Lots of things can happen in 3 months, including just serving tea and making photocopies for the organization. And therefore, what we have done is identify the specific tasks that we want our students to engage in. We want them to do individual counseling. We want them to do group counseling. We want them to hold some family sessions. We want them to have some psychoeducation. We want them to do some assessment. So we want them to do some case management. So all these, and paperwork and intake and screening and outreach. So all these activities that make up, treatment programs, we want to ensure that they are engaging in them. And therefore, we have got a way of, we have a very big document that tells them what to do in each of these areas. And so when we do evaluation, we have an evaluation criteria that looks at all these areas, but at the same time, looks at the competencies of the students across different areas. So when we developed the program, we had what we called competencies, skills, attitudes, and knowledge that we wanted the students to achieve. And so what we have done, we have come up with assessment areas that touch on each of those capacities, so that when we are evaluating every student, we evaluate them across each of those competencies. And we use what is called multiple methods of evaluation. They're evaluated by their lecturer who supervises them every once a week on the university campus. We have got the site supervisor, who is the supervisor at the treatment center, who's there with them every day. We do make a visit to them once in a semester to go and see what they are doing. And then they submit written reports of their work. And then they do case presentations, and they give us also samples of their case notes. So we do all these comprehensive evaluation to be able to assess whether the competencies that we hoped that they will achieve, they are actually achieving. Thank you.
Excellent. Okay. Do the students of the postgraduate program have to pay for the whole program, or does the university give out scholarships, especially for people with substance use disorders who want to pursue a career in the addiction field?
Good question. Sounds like it would have been nice if it was that way. I remember that when I started, I said one of our challenges is shrinking funding to universities. And believe you me, we do not have scholarships for students. When we first began this partnership, we had hoped that there would be some funding for scholarships to the program from Colombo Plan, but that did not necessarily take off. However, the students currently pay for themselves, and they are willing to pay for themselves, but we are also encouraging, and we are reaching out to organizations to sponsor their own staff to get into the program. And I am very keen to see that happening, because, and some of the good things happening is that already the students we have in our first class, they are already doing a good job where they are, and some of them are working students. And so in their workstations, people are getting to see something different about the way they do things, and getting to want to know what it is that what's making them do things differently. Even in the treatment centers where they're attached for practicum, they're actually people are beginning to see there's something different about how they do things, and getting to be interested in where can we get that knowledge. And that for me is important, because then more and more people are going to come to class, and more stakeholders are going to invest in sponsoring their own staff to actually come for this. And then that will help us achieve our goal of promoting capacity for evidence-based practice, because that's really where we are looking at. Thank you.
What is the required qualification or certification of the lecturers for the program?
So for us to teach this program, you must at least have a master's or a PhD in a related field of psychology, counseling, medicine or psychiatry, social work. But in addition, you must also have done the walkthrough. So for us, the walkthrough is very important because then you get to standardize what we are offering, because we know people are coming from many different backgrounds. So the walkthrough is critical, and that's why, Kerry, as you may know, that we are pursuing the walkthrough as an important, gateway towards offering drug demand reduction programs. Because if we don't do that, then we're going to have drug demand reduction programs which are not necessarily based on evidence-based curriculum. And that's why for us, walkthrough of the UTC, of the UPC are actually important criteria towards development of curriculum and programs that are going to stand the test of time.
Yeah. Clara asked, do you have an e-learning or distance learning in your program?
So in my university, we do have an entire school of, it's called the Digital School of Virtual Learning. And our hope is that as we stabilize our program of Postgraduate Diploma in Addiction Treatment Science, we're going to put it onto the digital learning mode. But I do believe, and I think I believe this as a former head of department of my Department of Psychology, I do not like to rush to take a program to virtual learning before faculty have understood and grasped the content, so that then they can be able to translate it into a virtual learning. Because believe you me, distance and virtual and open learning can be a lazy way of pretending to be teaching. It can actually be abused. And so I do believe, and my university does believe, and my department does believe, that we want to understand and grasp the content well. And one of the way to do that is to teach through the face-to-face model. And once faculty have understood the curriculum well, the same faculty would now translate that into modules and methods that can be used to teach the same program using virtual means. So that's where we are.
Okay. Someone asked, is it possible to share the practicum evaluation document?
Yes, it's possible. As we move along, I will be glad to share some of the documents that we used and some of our experiences. I believe using even other fora that we'll probably have in future. Mm-hmm. And I would be glad to do that, yes.
Okay, great. Yes, in fact, maybe we'll have more work in the future really around the practicum. I think we've discussed that with you. So it seems like there's a lot of interest in that area. Okay, we have a few more minutes. Someone asked, can students work full-time and part-time while taking the courses?
Kindly say that again.
Certainly. Can students work full-time or part-time while taking the courses?
Yes, depending on the mode they're taking. Currently, we have begun with full-time. So because we are doing full-time, that means they study during the day. They can only be students who we're doing part-time actually. We're doing part-time evening classes. So because we're doing part-time evening classes, then it means they can work actually during the day. So our classes run between 5:30 p.m. and 8:30 p.m. Kenyan time because they are 3-hour classes. So they can actually work during the day and study in the evening. We also intend to have the regular mode where students who are not working and they have all the time can actually be in class full time. At the same time, we intend to also have, in my university, we have another mode of learning that's called institutional based. What that means is target people who work like for 3 months and take a holiday the 4th month. And that means that we can structure the program so that they learn during the holiday month. In my country, it's April, it's August, and it's December. We already have other programs that run on that mode, and we are hoping to be able to put this program on that mode. So again, people can work and study using that mode. And of course, finally, when we do the digital learning, people can study and learn and work at the same time. Thank you.
Okay, and perhaps our last question. Is 3 months feasible to meet these expectations?
3 months.
For the practicum, I'm sorry.
Please clarify that. Is that for the practicum?
Yes, ma'am.
Okay. You know, the period of time that you give practicum does depend on the nature of the program. For example, in my department, we have several programs that run on practicum. We have got counseling psychology, which we have for bachelor's and master's and PhD. Our students of PhD, for example, will do 1,000 hours of practicum, which takes a year. Our master's students do 500 hours of practicum, which takes about 4 to 5 months. So our postgraduate diploma students then do a 3-month program, but a total of about 300 client contact hours. Now, client contact hours means the time that the student is with the client, doing some client work, whether it's assessment, whether it's counseling, whether it's case management. And we also have space for other practicum hours, 100 hours. For example, for doing things like case conferencing, case consultation, supervision, paperwork. So it is feasible because of the competencies we want to achieve and also considering the level of the program. If we do a master's program, for example, we will expect the students to take a longer period in practicum and to do more practicum hours. If we do a PhD, then it gets even higher. So I think that's how we have looked at it.
Well, I would just want to thank you for your time and shared such amazing information with all of us. We will post the recording as well as the materials on our ICU DDR website and our YouTube page. So give us a little time to get that posted. If anyone wants to look back at anything or has additional, colleagues who might want to look at it, it will be posted. Thank you again for your time, and I hope you have a great rest of your day.
Thank you. Thank
Be
you.
well.
Thank you to all of you.
Be
Bye-bye.
well, everyone. Take care.
Keep
Goodbye.
safe. Thank you.
I'm getting lots of nice comments in the chat, so make sure you take a quick look in there, Dr. K, before you go. Everyone is saying what a wonderful job you did, of course.
Thank you. Thank you. Thank you, Carrie. Thank you for your support.
Always. Thank you.
Thank you. And your encouragement. It's awesome.
Excellent job. We all appreciate it.
Thank you.